Welcome to Variations 4, the cardiovascular unit. In this video, we'll cover number 12, 13, and 14. Basically, we'll go through a quick discussion of what is cardiac output, which helps us to tie up a few concepts that review a few concepts we've already talked about. And then we'll cover question 12, which is looking at the electrical cardiac conduction pathway. And then we'll look at 14, we'll look at some basic ECG reading. So first with number 13, cardiac output. We'll look at map 14 for that. So what is cardiac output? Can you give the basic equation for cardiac output? Cardiac output equals stroke volume times heart rate. It's worth our while dissecting this a little bit because it actually helps us review varying interventions we have at different points in time in the cardiovascular system management. This will be clear by the time we finish this little discussion here. Cardiac output we could think of as being closely tied to perfusion, and that if you have an optimal amount of cardiac output, all things being equal, you've got some decent blood pressure going on and you've got some decent perfusion. Of course, there's always exceptions to that. Narrowed lumens, clots in the way, etc., etc. Inflammatory processes, who knows? But generally speaking, if you've got a heart that works well and the cardiac output is good, then you would think your blood pressure and perfusion would be good. And so the aim of the game here, a lot of the time when we're talking about cardiovascular function, really, what's the primary goal? Like if I was to say to you, give me one word that summarizes a healthy cardiovascular system, what would that one word be? I'll give you one word. You can give me one word to summarize a cardiovascular system that's working well. What would that word be? It wouldn't be oxygenation because that's the respiratory system. The respiratory system is responsible for getting us the oxygen. But you're on the right track if you're thinking that. The one word I'm thinking of is perfusion. If everything's being perfused well, all tissues and organs are being perfused well, then we really can't ask anything more of the cardiovascular system. That's all we really want. And I think it's important to get to that realization that what everything comes down to with cardiovascular is perfusion, ultimately. That's what it is. And that's really important to be clear on that before we dive into the right side of the equation here. Well, let's dive into the right side of the equation. So this part here, stroke volume. What are the determinants of stroke volume? That means with each contraction, with each beat, what do you want to happen? What are the elements that dictate how much is coming out with each beat? There are three major issues we can break down into. Number one is contractility, and that really is saying when that heart muscle works, when it's acting, is it acting in a way that is organized and rhythmic? Regular rhythm, for example. Is it organized in that when it contracts in a way that is what we consider to be healthy and a full contraction, or is it kind of some kind of fibrillation where it's weak, it's patchy, it's unorganized, it's not a full contraction, maybe it's flopping around, in terms of its organization? Is that contractility well organized, disorganized, strong, weak? What is the nature of each contraction? And that's something we see a lot of. And so can you think of, for example, can you come up with two medications, um, or just one would be fine, actually. One that you've given before, definitely. I think you've seen this in level 2, and you've definitely heard of this drug, or a class of drugs. We could go that way too. But can you think of a drug name that really addresses contractility of the heart? Digoxin would be one. So not only does it slow down the rhythm to enable filling, proper filling of the chambers, it causes the heart to contract in a more organized and powerful manner. So each contraction becomes more organized and more powerful. So that would be an example of a drug we're giving. So you can think of this as digoxin is a drug we give, sure, to give us optimal cardiac output. What part of cardiac output is digoxin addressing? More than anything else, it's addressing an aspect of stroke volume, and that is the contractility part of stroke volume. Okay, another element of stroke volume is preload. So this can go both ways. I mean, preload and afterload, as we discussed before, I mean, you don't want your circulating volume to be too low. And at the same time, you don't want it to be so high that the heart has to work so hard to push blood through, like in the case of CHF. CHF would give you what? A high afterload or a low afterload? An exacerbation of CHF would give you a high afterload and possibly even a high preload, depending on how much return. I mean, it's kind of a big circle here. Preload and afterload are usually fairly closely related. So, I mean, if preload and afterload were too low, what is that? What is that? That's like a low blood pressure, for example. Then we'd be thinking about giving IV fluids, which is a logical intervention. Typically, cardiovascular patients have an afterload that's too high, and potentially a preload that's too high as well. CHF is a perfect example. What's a med you could think of that we give for lowering afterload and making an optimal preload? A diuretic. A diuretic shaves off the fluid portion of blood, thereby decreasing our afterload and optimizing our preload and the whole deal. Okay, so hopefully you got a little bit of an idea of stroke volume here. Okay, the last portion of cardiac output is heart rate. So now you might be thinking about if the heart rate is too fast, like in atrial fibrillation, you've got a couple of problems. You've got disorganized contractility. We already talked about that, already done. But you've also got the issue of a heart that's going too quickly. And part of that's because of the fibrillation. But again, when you think of a drug like digoxin, it addresses the contractility. It also addresses the rate, brings the rate down. Can you think of another common drug that controls heart rate and also has an impact on blood pressure? A beta blocker, like metoprolol, would fit into controlling heart rate. Actually, a beta blocker, see, a lot of these drugs go into more than one section of the equation. A beta blocker affects heart rate. It's also going to affect afterload and potentially preload as well. If you're confused about the connection I keep making about afterload and preload, you got to remember it's a one big circuit. Blood comes from the heart, blood returns to the heart. And in the center of all that is blood inside the heart. So it really is all connected. But the reason why they separate the two is you can have certain problems with the heart wall, certain problems with emptying that give you preload issues. You may or may not have afterload issues. Of course, you can have something like CHF where you might have issues the whole way around. You might have stretching of the walls of the heart chambers because the preload's so large because of the CHF, as well as a high afterload. So that's why the concepts are separated. They're kind of one and the same, but because what condition the heart chambers are in and what the contractility is like, you can have there might be some differences between the two, but they're certainly very much connected.